Good evening, friends. I'm Dr. Aajay Shah, bringing this another great evening live. Today, I have a special guest, actually. I know our guest for last about 3 years now. He's a community leader. He's actually a community organizer. He himself is a physician, a great friend, and the thing I like about him, he's a great health advocate for many underserved people in my community. So I really admire him because he has dedicated actually his life to serve the people in need. I know many physicians who are actually busy, making a lot of money, doing a lot of procedures, prescribing a lot of medications. But our guest has actually dedicated his life to serve every underserved person in my community. And that's the reason we are bringing him today. As you all know, we have different pillars which we try to respect and serve on our page. And today's pillar is going to cover many aspects. Like I said, leadership, he brings the leadership. Civic duties, he brings the civic duties. Being a physician, he brings a lot of the healthy lifestyle pillars. So I'm very honored and very privileged to welcome Dr. Farhan Bhatti. Welcome, Dr. Bhatti.
Thank you so much. That's very kind of you, and it's my pleasure to be with you tonight.
Oh, thank you. So let's start with where do you live now and what kind of doctor are you?
I live in Lansing, Michigan, and I'm a family physician. I run a nonprofit clinic called Carefree Medical. So what we do is we provide medical, dental, and optometry care to individuals in the community who otherwise would go without. These are people who have Medicaid or Medicare, or they're uninsured, and they have a very difficult time accessing primary care elsewhere.
Wow, that's very impressive. We'll talk about that, a lot actually, but I just want to cover first 20 minutes your views on the 6 pillars of healthy lifestyle. So let's start with nutrition. Where do you stand with your views on what, as American, we should be eating?
So that's a great question. Um, I never miss an opportunity to talk about nutrition with my patients, especially at annual physicals or preventative health visits, as well as diabetes checkups, high blood pressure checkups, and even mental health checkups, because what we eat also has impact on our mental well-being. Um, so there are many different fad diets that are out there. But the most important thing that I talk to my patients about is eating a diet that's high in fiber. The average American diet contains 5 grams of fiber a day, but the recommended intake of fiber is 25 grams a day for men and 20 grams a day for women. And so however they want to get to their 20 or 25 grams, I'm all for it, whether it's increasing their intake of fruits, vegetables, whole grains, because the more room that's occupied in their stomach with these kinds of healthy foods, the less room there will be for unhealthy foods. We also talk about avoiding processed foods, foods that are high in fat, foods that are high in carbs, cholesterol, processed meats, etc. Um, but at the end of the day, if I try to make things simple for my patients. So if they can focus on increasing their fiber intake, then they're going to be less available to eat foods that are low in fiber and that are less healthy for them.
Wow, that's an excellent answer. And I'm in the same boat actually. Fiber should be the most important nutrient in our diet. I agree with you. I think many of the Americans think the protein is the most important nutrient, but actually, more protein we eat, earlier we die, and more fiber we eat, longer we live. So I think you made it very simple for all of our viewers. Number one, give the importance to the fiber. Let's talk about the second pillar. Second pillar is the physical activity. How do you recommend your patients and how do you recommend to our followers in terms of starting a physical activity and maintaining a physical activity?
So it's very easy for it, and I've seen doctors do this. I've seen doctors just say, okay, between now and the next visit, I want you to exercise for 30 minutes a day, 5 days a week. And then they say, I'll see you later. And, it's important to set realistic goals for patients when they're first starting out with exercise. So in my residency training, they taught us motivational interviewing. So we ask the patients to set the goal. What is a realistic goal between now and 3 months from now that you think you could do as it pertains to exercise? And even if it's a modest goal, even if it's I'm going to run on the treadmill twice a week, I'll say, great, let's start there. How confident are you that you're going to be able to do that? And what are the obstacles that are in your way from accomplishing your goal? So then we outline and we talk about their confidence rating and what barriers they see for them to be able to achieve their goal. And then we build off of it. So then moving forward, once they've been able to get that under their belt and they're doing their twice a day exercise or whatever it is that they said that they could realistically do, then we aim for more and we keep building more and more until they get up to, you know, a healthy recommended amount of exercise. And so I think that's the best way for people. Everybody has different starting places. Not everybody is used to rigorous exercise. Some people were very physically active when they were younger and then they lost it. They got busy with their adult lives. Some people never did exercise when they were younger. So we try to meet people where they are and then set goals together that are realistic for them to achieve first, number one, and then we build off of it together.
I think that's an excellent recommendation. I think start slow and build it up and get to the recommended amount, which is 150 minutes per week. How about sleep? Sleep is another important pillar. And how much sleep you think an American should get, and how do you recommend your patients how to get a good night's sleep?
Sleep is so important. And of course, as you might imagine, because I serve an underserved demographic, mostly low income, uh, these people have unique challenges, many of them facing obesity. And so sleep apnea is a big thing that many of my patients have that and many of them have gone years before it's been diagnosed. I have a very low threshold for ordering referrals to sleep medicine because if you're not getting a good night's sleep, if you're not getting that 8 to 10 hours, depending on the individual, you become physically sick and you also become mentally sick. One of the things that I explain to patients is when we're talking about depression or anxiety, if you take a person who doesn't have any history of mental illness and you sleep deprive them, what happens? They get irritable, they get moody, they get anxious, they feel down because they're not getting a good night's sleep. And in the context of sleep apnea, they could be trying to sleep for hours and hours, but they're still not getting good quality rest because their brain's not getting enough oxygen when they are sleeping. So, regardless of how many hours they sleep, they're not getting restful sleep. And so they're always in a state of chronic sleep deprivation. And so we do talk about, yes, getting a healthy number of hours, but there are many people who fall into the obese category who are getting a healthy number of hours, but they're still not getting good quality restorative sleep because they have sleep apnea. And that's essentially where they stop breathing when they're sleeping and their brains aren't getting enough oxygen because they have narrow airways, usually in the case of obesity because of thick necks, which then causes the airway to become more narrow. And so sleep is not just number of hours, but also quality. And so, what are some signs of sleep apnea that the viewer should look out for? So, if you are an individual who, no matter how many hours you sleep at night, if you wake up in the morning still feeling tired, low energy, that's a sign. If you wake up with a headache, that's a sign. Uh, if you find yourself needing to take naps during the day or wishing you could take a nap during the day because you have daytime fatigue, that's a sign of sleep apnea. If your partner tells you that you snore when you're sleeping, that's a sign. And if your partner tells you that you might stop breathing while you're sleeping, or if your body awakens you multiple times at night to breathe, that's also a sign, multiple nighttime awakenings. So all of these things put together are very, very common in overweight and obese Americans and individuals. And so in the context of sleep, uh, we, uh, we screen all of our patients to make sure that they don't have sleep apnea uh, or any kind of sleep disorder because, uh, again, it's going to cause great harm to their mental well-being and their physical well-being if they're not getting restorative sleep.
No, that those are excellent points, and I agree with you. I think even though people may be spending 7, 8 hours in the bed, but if they are obese, like 42% of Americans are obese, sleep apnea has become such a common diagnosis. And I remember in my own practice, sleep apnea was one of the most common diagnoses as obesity got worse. So I think I agree, and I'm glad you lined up all the symptoms and signs of sleep apnea because many of our viewers, some of them still have sleep apnea which is not diagnosed, and they should ask their physician for a sleep screen, and it's a simple questionnaire. If they meet those questions and if they have positive answers, they should have a sleep screening done, and if needed, a full sleep study done. I agree with you. I think let's go to the next pillar. The next pillar is the stress management. With COVID-19 and everything else going on in America right now, stress is a major issue. So how do you recommend your patient to manage stress, and what are the best ways to overcome day-to-day life stress?
So actually, one of the pillars that two of the pillars that we just finished talking about uh, help with stress. Number one is exercise. Exercise is a great way to burn off steam, a great way to help with depression and anxiety. In fact, there was a study that was done, and it was a study that took individuals with severe depression, and half of the people were given antidepressant, and the other half of the people were given a strict daily exercise regimen. And they followed them over time. And they found that their improvement in depression scores was the same between the two groups, the medicated group and the group who's doing daily, consistent, regular exercise, which is hard to accomplish. But in the context of a clinical trial, it proves that if you are uh, really motivated to do that, you may be able to even avoid taking medicine. And I tell my patients, think about how much better you might feel if you take the antidepressant and do the exercise. And so, uh, um, stress management is big, especially during the pandemic where people are going kind of stir crazy. They're stuck at home. Uh, Maybe they're not working as much as they're used to. I mean, I'm fortunate. I am a physician and I still go to work every day and see patients. And I myself would be going stir crazy in my house if I didn't have that outlet to go to work every day. So I can completely empathize with people who are stuck in the home. And now they're stuck in the home with their kids, and their kids are having to go to school online, and they might feel like they just don't have any escape. And so, healthy eating, fuel for the mind, and then exercise, fuel for the body. Those two things, along with sometimes medication from your physician and seeking help from a therapist, all of those things are a comprehensive way to help relieve stress and anxiety.
No, I agree with you. I think stress management is probably as important as other pillars, and they all actually interact with each other. And like you said, if a person who exercises regularly definitely has a lot better way of handling the stress. That brings the next topic, next pillar, which is actually very common in certain socioeconomic status, and that's a substance abuse and alcohol and smoking. I mean, obviously, you deal with a lot of patients in your own practice. I mean, it's prevalent across all the segments of the society. So, how do you handle the substance abuse, alcohol, and particularly smoking?
This one's hard because, like you said, this is pervasive across every group. You have, you know, poor people who have had the unfortunate circumstance of getting hooked, especially these days on opiates. Maybe they had surgery and they were given, a large amount of narcotics. Now they're done with the surgery, but they're craving the narcotics. Then they run out of pills, and it's much cheaper to get heroin on the street than it is to buy pills. And that's how rich and poor people alike often end up uh, on hard opiates. Uh, because of the price of these things on the street. And usually it's well intentioned, well meaning physicians that started it, that gave the patients the opiate for some chronic pain issue or some acute care issue like a surgery or a fracture or what have you. And so, opiate dependence is something that I literally deal with every single day in my practice. And it just requires a lot of patience and a lot of explaining to patients about how, you know, The opiates physically change the way that your brain perceives pain. So the longer that you're on opiates, the more vividly you're going to experience pain. It's a paradoxical thing. But essentially, that's what tolerance is you're on the medicine for so long that you need more and more to get the same pain relief you used to be able to get with lower doses. So um, I have that conversation very frequently. Uh, but then I find that, especially in my demographic that I serve, there is a higher incidence of undiagnosed or misdiagnosed mental illness. And so people who went their entire adult lives, maybe they were labeled as depression, or maybe they were labeled as ADHD. And when you dig a little deeper, you discover that actually this person has bipolar disorder. Um, and during their manic phases, they might have, sex, drug, or alcohol binges, and they're self-medicating with alcohol, or they're self-medicating with marijuana as a way to try to bring themselves down from the high. They don't understand what they're doing. They just know that when I take this drug, it helps me come down. And so we're doing in primary care a better job, but there's still a lot of improvement for us to do as far as recognizing bipolar disorder in primary care settings. 1 out of every 4 patients with a depression diagnosis in a primary care setting actually has bipolar disorder. That's been missed. 1 out of every 4. And those folks are much more likely to end up with substance abuse disorders because they're trying to self-medicate. And so when I encounter a patient with a substance abuse history, that's another red flag for me to, if I haven't already, to dig a little bit deeper into the history and see if I can uncover maybe some underlying mental illnesses that have yet to be discovered by the patient's previous physicians. With respect to alcohol, there are some treatments that are out there that we offer in my clinic and that primary care doctors can provide. One of them is antabuse, of course. So that's a medicine that people can take so that if they drink alcohol while they're on the antabuse, they will get sick, they'll get nauseous, they'll get vomiting. And so it's a deterrent because you know that you're on this medicine, and then if you drink on top of it, you're going to make yourself sick. There's another medication, though, that's gaining popularity that I actually like better. It's called Naltrexone. It comes in pill form and injectable form. The injectable form, the brand name is Vivitrol. So what this is it's a medicine that doesn't make you sick if you drink on top of it. But what it does is it reduces your cravings for the alcohol in the first place. And so patients who take naltrexone daily or who receive the Vivitrol injections once a month, very good data that it helps reduce the cravings for the alcohol and helps them achieve sobriety and then maintain sobriety because we continue the naltrexone for some period of time, even after they are in remission from their alcohol abuse disorder. And so if you are an individual who might be suffering from that, talk to your doctor about that possibility. And then, of course, smoking. I mean, smoking, I have patients who come and see me and they have diabetes and they might be motivated to change or improve their blood sugar. And I will look at them and I will say, even if we get your blood sugar to perfect, by far your biggest risk factor for having a heart attack and stroke and dying early is your smoking, not the diabetes. So yes, I want you to get your diabetes under control, but if you don't stop smoking, then the relative risk reduction is low for you. And so I try to get people to see things in perspective. And, the single most important thing that an individual who smokes can do to statistically increase their life expectancy and statistically improve their quality of life is to quit smoking. More than anything else, more than diabetes, more than blood pressure, all of those things are important, but not as important as quitting smoking. And so, again, there's various different ways to help with smoking cessation, nicotine replacement, Chantix, Wellbutrin. There's lots of different options. Different people respond differently to different treatment options, but I would encourage you, any viewers out there that might still be struggling with smoking addiction, to really think about, we're talking about healthy living, we're talking about diet and exercise, and we're talking about stress, and all of those things are trumped manyfold by the smoking as far as the impact that it can have on your quality of life and life expectancy. So I really want people to reflect on that if they are in a circumstance where they're still smoking.
Wow, I mean, you covered it so well. You started with opiates, you covered alcohol, you covered smoking, and you gave not just that we should not do that, but you gave us all the details how we can overcome all those substance abuse and addiction. So, I mean, that was very impressive. That's very good. And let's talk about the last pillar, which is also another important pillar, and that's our relationship with our spouse, with our partner, with our family, with our friends, with our community. So, please give us your views on importance of relationship in terms of healthy lifestyle.
Well, human beings by definition are social beings. So it's not natural for a human to be isolated. We need those social interactions and social support to help us with our physical and emotional well-being. You know, having a life partner is uh, is great because it helps motivate you to do right, not just for yourself, for your family. If you have children, you might, be more motivated to lose weight and start exercising because you want to be around for them and you want to be around for their children. And so having a supportive family is essential, um, or at least gives people a great leg up in their ability to make lifestyle changes. Um, every illness, whether it's physical illnesses or whether it's mental illnesses, every illness can be improved, not solved, but improved simply by having the support of people around you that you trust, whether it's family, whether it's neighbors, whether it's community, whether it's your physicians, whether it's, your faith community. Um, that having that support is what allows human beings to really thrive and reach levels of physical and mental well-being that I personally don't think you can reach if you just try to go it alone.
Yeah, I think I agree with you. I think loneliness actually is as bad as smoking. So I think I agree. I think relationships are very important. So that's a great coverage of all the six pillars. Now I want to dive into actually your work, which you do every day with so much commitment, so much passion, so much dedication. So let's talk about the community-based clinic you have for the low-income families, for the underserved people. So how big is the clinic? How many total patients you have now? How long you been doing it? And how do you get the funding for that clinic?
Okay, so we'll start with um, how long we've been around. So Carefree was started in 2004 by a gentleman named Barry Saltman. He was a physician who was approaching retirement from private practice, and he decided when he retired, he wanted to be able to give back to the community, people who didn't have insurance. Um, he and his wife, who his wife was a nurse practitioner, so they decided maybe a half a day a week we'll keep our private practice open and take care of people without insurance. But within 6 months, there was a line of people out the door waiting to get in. The local newspaper ran a story about what they were doing. And so they weren't able to really achieve that vision of just half a day a week taking care of people. They decided to keep their clinic open full time, Monday through Friday, and just put off retirement. And so that was how Carefree originally started. My involvement with Carefree dates back to between my first and second year of medical school. He came and gave a lecture to us at MSU about who he was and what he was doing. And I said, that sounds great. Let me volunteer. So I started coming once a week and just learning my physical exam skills. And after doing that for maybe 6 months or so, he looked at me and he said, I'm 72 years old. I'm not going to be around forever. So how would you like to have this place when you finish your training? And at that point in time, I still had like 6 or 7 years of training left. So, but I thought about it and I said, yes, it sounds like a great opportunity. It sounds like exactly what I want to do. with my life is, serving others. And so we committed to each other very early in the process, and we kept our commitment to each other. Over the years, Carefree has grown. So, in 2000 and approximately 2009, we added a dental clinic, and then a little bit later, we added an optometry clinic and a behavioral health clinic. So there's many different entities underneath the Carefree umbrella. I've been the CEO now for 5 years because I graduated residency 5 years ago. And we've grown a lot. So now we are the primary care home for almost 6,000 individuals across Metro Lansing. And we provide over 15,000 office visits per year. And these are people who, if it weren't for us, their only recourse would be to go to the hospital emergency departments, which is not a cost-effective care, and it's not even good care because they're not getting any continuity. And so I'm very blessed and fortunate to do the work that I do because it's a tremendous asset in every community to have clinics like ours. We're the second largest safety net entity in our county. The only entity larger than us is the Ingham County Health Department. And we partner with them because the need is so large and the need is growing. And so there's not enough safety net providers to care for all the people who need it. So there's really not a whole lot of competition in our space. We take all comers, and we do our best to leave as large of a footprint as we can to help people. I mean, before the passage of the Affordable Care Act, most of our patients did not have health insurance. And many of them went their entire adult lives without any health insurance coverage. And so they have all the diseases that, people in the rich suburbs have, but they're more advanced. Their diabetes is worse. Their obesity is worse. Their blood pressure is worse. Their depression, anxiety is worse. Everything's worse because they went often for decades without getting access to any care. And so we do our best to try to unwind all of those decades of damage that their bodies have suffered, along with all of the social barriers that people have to care. It's not just, a matter of telling somebody to go eat healthy. If they have a limited income, they might not be able to abide by that as well as you'd like them to. So we have to take into account all of the health disparities that exist. And we have to try to meet our patients where they are and help them grow as individuals. So that is Carefree in a nutshell. We have 3 full-time providers, myself, another physician, and a nurse practitioner in our medical clinic. We also train residents from Sparrow Hospital. So third-year internal medicine residents come, mandatory part of their curriculum for 1 month at a time. They come and they see patients with me, and they learn from me. And then we also have a similar setup in our dental clinic where we get dental hygiene students that come and help us see patients, but also learn what it's like to practice medicine in an underserved area. The biggest driver of getting more providers to practice in underserved areas is exposure by far. So if you were a medical student or a resident who was exposed to an underserved clinic and an underserved patient population during your training, you're much more likely to make that part of your career when you finish your training compared to somebody who never had that exposure. So that's what we try to do locally, is try to get other people motivated to take care of the underserved. Maybe they can't make it their full-time job like me, but maybe they can agree to not be part of the problem. Like you mentioned in your introduction, there are many physicians in the community who don't take Medicaid at all. And they do that because Medicaid reimbursement is so low that it's basically like providing charity care. And so it's not in their clinic, and it's not in their business's best interest to take large volumes of Medicaid because they're going to lose money. But if that demand was spread out across many different providers across the community, and if everybody did their fair share, and if everybody committed to maybe having 5% of their patient volume underserved, then we could spread that out across many different primary care providers, and then no single entity would be responsible for bearing that financial burden that comes with taking care of large volumes of Medicaid patients. The only way that we're able to take care of such a large volume of people with Medicaid or people who don't have insurance at all is we have to go out in the community and raise money. 1/3 of my budget is private donations that we solicit and grants that we apply for and fundraising events that we hold every year. And if we weren't able to get access to those funds, we wouldn't be able to keep our doors open because Medicaid just doesn't pay enough to compensate your providers, your support staff, your medical assistants, let alone being able to pay your rent and your utilities and all of the overhead that goes along with running a practice. It's just not financially feasible to be able to pay those bills when you're taking care of underserved patients because of the insurance situation, the reimbursement situation. And so, and especially that's true in Michigan, because Michigan, out of the 50 states, Michigan is in the top 5 worst states for Medicaid reimbursement. So in Michigan, we reimburse 62 cents for every Medicare dollar. That's the Medicaid reimbursement, 62 cents. And even Medicare dollars is not enough for clinics to completely break even. So if you are getting paid 62 cents on the dollar for every service that you provide, the math becomes very challenging if you're in private practice to keep your shop open. And hospital systems are able to absorb more of the financial burden because they see more patients with good insurance to offset the losses. But still, it's a challenge for hospital systems as well to provide primary care to Medicaid. So what a lot of people don't understand is that, yes, the Affordable Care Act expanded Medicaid and 640,000 people in Michigan got access to health insurance through Medicaid. But just because they have insurance, it doesn't mean that they have access to care. They have a health insurance card, but that doesn't mean that they can actually find a doctor who accepts their insurance card. And so certainly, I think Medicaid expansion was important. It was great. And I'm glad that we're able to give Medicaid insurance to people who before they didn't have anything. But those people are still very challenged to find providers, especially specialists, because in cities like ours, it's difficult or sometimes impossible to find specialists who accept Medicaid. For example, there's not a single board-certified dermatologist in Ingham County that accepts Medicaid. There's not a single neurosurgeon in Ingham County who accepts Medicaid. Orthopedic surgery has quotas. After they meet their quotas, they don't accept any more Medicaid. So for patients who need these services, they end up having to go to larger tertiary care centers. Like for us, usually it's the University of Michigan or Henry Ford Hospital in Detroit. They have to drive an hour and a half to find a specialist who accepts their Medicaid. Meanwhile, a lot of our patients don't even have access to transportation. So it becomes very challenging for people to get the care they need, even when they have insurance. And so that's why it's so important for people to understand the economics of medicine and for our policymakers to do something about that, because it's fundamentally not going to get better unless the reimbursement gets better, so that it's not cost prohibitive for private practice physicians to accept Medicaid patients.
Wow, you cover so many things. And let me also tell you, Dr. Saltman, a great friend. Matter of fact, as you recall, my old practice of cardiology, I had given that building to him so that way he can start his clinic and expand on it. So I'm very proud that you have taken over. You actually fit in his shoes completely well. you actually are as passionate like he was. Unfortunately, he died last year, but he served the community so well. Even when he was in private practice in Mason, I remember working with him for 15 years in Lansing area. He was always the most caring, most passionate, most compassionate person I've ever seen. So I agree with you. So thanks to Dr. Saltman to get you into this program. And I also agree your life philosophy and your vision that if you expose many of these residents early on into this kind of practice where they are seeing underserved people, hopefully some of them will be like you who will be doing full-time practice in underserved, but at least most of them will have some kind of compassion to keep accepting at least 5 to 10% of the patients in their own private practice who are underserved. And like you said, if the burden is shared by every physician, we will not have the shortage to take care of these underserved people. And I think it's unfortunate that there are some specialists who don't think that way. But I think person like you will eventually will change a lot of the future physicians. So that's very, very commendable, very, very impressive. So let me ask you a practical question. You have now years of experience, and we have obviously with this COVID-19, with a lot of the loss of jobs, we have a lot of low income families, even a lot of middle class. So what are your top tips for any low income or middle class family, how to stay healthy and how to lower the healthcare costs?
So, low income families staying healthy. Uh, that is generally a team approach, because it requires the help of clinicians, oftentimes dietitians, social workers. I usually try to help my patients come up with a realistic budget. What can you reasonably afford on food every month? And then we try to make recommendations that fit their approximate budget. Because it doesn't make any sense to go tell them to go to Whole Foods and buy a bunch of organic stuff. That's not practical. And so, somebody who is low income, I would encourage them, if you haven't, to actually take pen to paper and write down what are your monthly expenses and what can you reasonably afford to spend on food for your family, and start there. And then come up with uh, foods that are high in fiber that we talked about, and come up with uh, how you might be able to get to your 20 or 25 grams of fiber per day, given your budgetary constraints. Um, and then, of course, it, it doesn't require any money to exercise. Exercise is, to some extent, an equalizer. Of course, people who are wealthy have access to fancy gym memberships, etc. But you don't need that in order to be healthy. That's a luxury, not a necessity. And so, people who are low income, I still tell them, you know, uh, as long as you live in a neighborhood that's safe, where it's safe to go outside, then take advantage and go outside and spend some time getting your heart rate up and breaking a sweat. I don't care how you do it, whether it's walking fast or jogging or biking or swimming in a neighborhood pool. Anything you can do to get your heart rate up and break a sweat is what I want. Because some people will, when I ask them, what do you do for exercise? They'll say, oh, well, I clean the house. Or, oh, well, I take my dog for a walk. And I say, that's okay. But what I mean by exercise is something you can do to get your heart rate up and break a sweat. So, certainly, a leisurely stroll around the block with your dog is better than sitting on the sofa. But that's not actually exercise, according to my definition. Exercise is cardio, aerobics. So, getting your heart rate up, walking faster. And I tell them I'd rather have you walk at a fast, brisk pace for 20 minutes than walk at a leisurely pace for 45 minutes or an hour, because you're going to get more bang for your buck and you're going to end up saving time if you use the time more efficiently and get a good cardiac workout in a shorter amount of time. And so, uh, if you are low income, but at least you live in a safe neighborhood, you have access to a park, uh, then perhaps you could take advantage of the warmer weather we still have and go outside. it's even more challenging for people that live in neighborhoods that aren't safe, where there's a high degree of crime. Maybe they don't feel comfortable going outside or taking their kids outside. And so then you have to be a little bit more creative about what you can do to exercise, maybe inside your home. But if you have stairs in your home, go up and down the stairs 20 times, do reps. Maybe do that 3 or 4 times a day where you do the stairs in your house. So there's creative things that you can do, even if safety is a concern for you in your neighborhood. And so these are conversations that we have. Doctors can't solve every problem when it comes to this, but we can solicit the help of others, including social workers, dietitians, etc., to help us help our patients.
Wow, no, I think I agree. Those are excellent tips. And I think I always have said that the 5 pillars out of the 6 pillars actually cost nothing to start from tomorrow. They don't have to even wait for a week. They can start tomorrow. Like you said, if it's a safe neighborhood, they can go for a walk tomorrow. Same with relationship. You can find good friends to socialize and go to church or go to temple, go to a mosque. And I think food obviously costs money, but on the long run, healthy food actually is much more cost effective than unhealthy fast food, which costs, as I understand, each dollar of French fries cost $8 in 20 years in the healthcare cost. So I think I agree with you. So let me ask you, what are some of the programs available for low-income families? You talked about Medicaid. Are there any other programs, for example, can they sign up for certain pharmaceutical company help in terms of their medications, in terms of some of the equipment they need to get, or scooter, or any other equipments or supplies they can get? What kind of access they have to some of the other programs other than Medicaid?
So if a person doesn't have any insurance, um, they can get even very expensive medications for free directly from the drug companies. Um, the pharmaceutical industry, believe me, they're definitely not perfect. Um, and we do definitely need to lower healthcare costs in our country. But one of the good things that all the drug companies do is they have charitable programs. So if people meet income eligibility criteria, and sometimes the income eligibility criteria is very generous. For example, there's a drug company that makes Tresiba insulin, and their charitable program eligibility for a family of four is a income of $100,000 or less. So if you're a family of four and you make $100,000 or less, you're eligible for free insulin from that drug company. Um, and depending on the drug company, they have different cutoffs as far as income. But if you don't have insurance and you really need uh, a mental health medication, for example, some of the new bipolar medicines or schizophrenia medicines that have yet to go generic, they can cost 800 or $1,000 a month. And so without insurance, it's completely unaffordable. But those newer medications are often the ones that have the lowest side effects. Less propensity for weight gain, less propensity for dyslipidemia, less propensity to cause blood sugar increases and diabetes. The older antipsychotic medications like Seroquel, Zyprexa, Geodon, it's just a matter of time if you take those long enough that you end up with 20 pounds of weight gain and diabetes. But the older medication, the newer medications in that category, they don't really do that. There's one medication over 2 years, there was like a 2-pound weight gain in their clinical trials over 2 years. And so they really are doing a good job to come up with medications that are better tolerated for our patients, but that has a cost associated with it. But nevertheless, if your physician feels like that's the best choice for you, you can apply directly to the drug company and they'll give it to you for free if you don't have insurance or if you don't have drug coverage. In some instances, not in every case, but in some instances, even if you have Medicare, if you don't have a drug coverage plan with your Medicare, some pharmaceutical companies will still allow you to get their medications for free if you apply through them and you meet their income eligibility criteria. So medication is definitely something where, our society needs to do better, but um, there's hope for people without insurance as long as they can navigate the application process. And so that's one of the things that we do in my clinic, as well as I'm sure other safety net clinics do this too, where when we identify a patient who meets the income criteria to get a particular medication through a pharmaceutical company, and they don't have any drug coverage or they're uninsured, we will help them apply. We will help them fill out the paperwork and submit the application online or by mail so that they can get whatever medication it is that they need. Specifically to answer your question about other kinds of programs that are available here locally in Metro Lansing, we have overnight shelters, we have day shelters, domestic violence shelters. We have here in the city of Lansing down payment assistance programs. So low income families who are trying to buy a home, who need help with their down payment, there's help for them. Likewise, there's homeowner rehabilitation programs, which are a combination of grants and 0% interest loans. So low-income families who already own a home, but who need help with rehabilitation of their home, they can get funding through those programs. There's the Lansing Housing Commission, which helps people with short and long-term housing assistance needs. For food, of course, there's the WIC program. There's the Temporary Assistance for Needy Families program, which is run by the state. There's a Greater Lansing Food Bank. And then there's also community centers across the city that offer programming for at-risk youth, as well as adults and elderly people. So those are just some of the many resources that we have in our city that I'm sure every other urban city has stuff like this to help people in need, because it's not just about their prescriptions. It's about the world around them that's contributing to uh, making it difficult for them to live a healthy lifestyle. And so, um, also, I want to mention the Tri-County Office on Aging. They have a lot of resources to help with case management, caregiver support for people that are taking care of elderly individuals. They can help with Meals on Wheels. They can help elderly patients apply for Medicare and Medicaid, and they can help them navigate the process. They can help them choose different Medicare plans. So that's a great resource for people here locally to take advantage of.
Wow, this is such a comprehensive answer you gave us, and I think I agree with taking advantage and taking a benefit of all the programs available, and that's where I think I commend you being a physician that not only you help them to navigate through their medical care, but also their whole life, which includes many times food on the table, many times housing, many times transportation. I think sometimes even shelter. And I think all those things, I think you have actually become an old-time country physician, I should say, where that physician was helping the family in every sense, not just to take care of their health. And I think that's I wish more physicians are like you. So that brings my next question: that what is your vision, or what are your thoughts in terms of what our state government, for not Michigan, but for all the states in America, and also federal government, how can we overcome this growing crisis of chronic disease, of underserved, underinsured patients, underinsured people, and overall, how can we make our country healthier, both at a state level and a federal level?
Hmm. So at the state level, one of the things that I would advocate for is increasing the reimbursement rate for Medicaid. Um, and some people will say, well, that's just doctors being greedy. But it's not actually the case, because there's not a physician that exists in Michigan or in any state that's getting rich off of Medicaid patients. It's just not possible. Even if you see 40 patients a day and you work your butt off, if you're just seeing Medicaid patients, you're not making enough money to sustain your business. Um, and so if the state government were to prioritize um, reimbursement for these patients. Yes, now they have insurance. That's great. It's called Healthy Michigan Plan, and people can get coverage. But if they were to put some money behind the reimbursement rates for Medicaid, then more of those patients who got access to that insurance would be able to find providers who accept that insurance. And that's really the big thing. And the federal government should support the states because states are strapped for cash. Like if you're a state legislator and you're looking at the budget, what are you going to cut to allocate more funding for healthcare or Medicaid reimbursement? That's a difficult question because I know here in Michigan, we've already trimmed all the fat. We're down to skin and bones already with our budget. There's not a lot of waste. Some people, some of our conservative friends, one of their favorite talking points is government is too big. We got to trim the fat. We got to get rid of the waste. We've pretty much gotten rid of the waste in Michigan. So you have, apart from increasing revenue, which is raising taxes or getting more money from the federal government, what are you going to cut to fund healthcare? So that is a question about priorities, and that's a difficult philosophical question to answer in this conversation. Whether you cut from corrections, for example. We incarcerate so many people in our country compared to the rest of the world when we could be investing in their rehabilitation and helping them become productive members of society faster. Most people who go to jail or prison are coming out. Very few are going in and staying in for the rest of their life. And so for the ones that are going to come out, we have to do a better job of training them and giving them some vocational skills so that when they do come out, they can become productive. And we should change the way that we do our sentencing and get rid of things like minimum sentencing requirements. And we should stop putting people in prison for nonviolent crimes. So that's perhaps, if I were a policymaker, one area where I would look at, okay, how can we take this money that we have and spend it more wisely? Because right now, we spend so much money incarcerating people, warehousing people. Our jails and prisons are full of people who have mental illness. And it's very expensive to warehouse them in a correctional facility. And it's much less money to take that individual and give them the appropriate treatment they need to overcome their mental illness. And so there's so much progress that we could make on that front. And then I think that would free up some dollars to spend more on healthcare at the state level. But ultimately, we're not going to be able to cut our way out of this problem. We're going to need help from the federal government to allocate more funding for all of the 50 states to be able to provide healthcare to their people and to allow physicians to be able to take care of those people. Assuming that we continue to live in the current model, in the current healthcare model, the way to overcome the Medicaid challenge would be for the federal government to allocate more money for states to use towards reimbursement. That doesn't at all even address the people who don't have Medicaid, because still up to 10% of the people that I see on any given month are completely uninsured because maybe they make too much money to qualify for Medicaid, but not nearly enough money to be able to purchase health insurance on their own. Maybe they make $22,000 a year. Well, that's too much for Medicaid, but you can't really do much with that as far as buying a health insurance plan that's worth anything. You might be able to buy a health insurance plan with a $10,000 deductible. So again, that's just health insurance in name only. Those people behave the same way that uninsured individuals behave. They avoid seeking care because they have such a high deductible. But ultimately, my hope is that at the federal level, we can come up with a new model because the current.
I think that's an excellent point. I think you cover so many things again. I think as a society, I think our priorities has to be set to take care of the people. I think right now we are somewhat in a wrong direction. And I think I agree with you. I think our legal system needs to change, our sentencing needs to change, a lot of incarceration, and I think some of the saving we get from all those programs can definitely be applied to healthcare, to apply to college education, to apply to senior care, to apply to many other programs which are much more healthier for the society than just keep putting people in the jail. I agree with you. I mean, that brings my next question to you and your views is that there's a lot of talk about trying to get into a system like Canada has, Germany has, UK has, is a single payer system. And obviously there are pros and cons. What are your views on single payer system?
If you could, if you could design a system from scratch, then single payer would be the best way to ensure care for every American. But right now, you can't really design that system from scratch because there's so many health insurance companies in every state. Um, you can't even take health insurance across state lines. So, and those health insurance companies are firmly entrenched, and they employ thousands and thousands of Americans. And if you were to just come into Congress and wave your Bernie Sanders wand and say everybody gets Medicare for all and we're going to shut down all of these insurance companies, well, you're going to put tens or hundreds of thousands of people out of work that are employed by these health insurance companies. So there has to be a gradual way to get to something like single payer. You can't do it overnight. I think the best way to start is to introduce competition into the market. You want to talk about, a lot of our conservative friends like to talk about free market economics. Well, our health insurance system is anything but free market because the individuals in that market don't have the education or knowledge that they need to actually be rational actors in a free market. They don't know how much it costs to go to the hospital. They don't know how much it costs to go to this doctor or that doctor. There's no transparency in prices. So it's not actually a free market. They just like to pretend it's a free market. And so if you introduce competition into the market, and if the government were to set up something like a public option, so that's a government run, you can call it Medicare, you can call it something else, but a government run plan that people can buy into if they want, um, then that plan and the competition that it brings into the market would accomplish one of two things. Either it would force the other health insurance companies to retool and to lower their costs to outcompete the public option, or eventually the public option would win and drive the other health insurance companies out of business because they weren't able to lower their costs and compete. And so right now in the healthcare market, there's just not that competition. It's a bunch of individual health insurance companies making decisions about maximizing their profits at the expense of the well-being of everyday Americans. So uh, uh, when you have that public option, then you allow you allow the process to start of introducing competition into the market and then seeing what happens. And if the private health insurance companies are able to retool themselves and reinvent themselves and lower their costs and outcompete the public option, great, everybody wins. But if they can't, then uh, then perhaps that would someday evolve into a scenario where more and more people buy into the public option, and eventually everybody is more or less insured through the government. And so that would be uh, my proposed alternative because it just doesn't seem politically feasible to come in and say, we're going to do Medicare for all, we're going to close all the insurance companies down on day one. Uh, uh, that doesn't seem like a practical scenario. You mentioned Canada and Germany. There's many countries in the world that do healthcare better than we do. If I were to model our new improved healthcare system off of a country, I probably wouldn't model it off of Canada. Uh, I would probably model it off of Germany or even the UK or Australia. In Australia, they have a hybrid model. They have a public-private hybrid model where everybody gets access to the public insurance. And if you want to purchase private health insurance on top of that, you can do that. And you can get, uh, you know, access to different kinds of care perhaps more quickly with your private insurance. Um, but everybody at least has healthcare at their baseline. And so, you could employ a public-private model uh, as opposed to just having one single American healthcare plan. Um, that might be a little bit more logistically challenging. But uh, doubters of government-run healthcare, they love to point to Canada and they love to say, look at all of these things that Canadians can't do, and they have waiting lists and they need surgery and they can't get it. And so I would say, look at other countries, because there's plenty of other countries in the world that do health insurance better uh, than Canada and the United States. And so let's study them and see what we can learn from them.
No, I think it's a very comprehensive answer you gave us, and I agree with your proposal that start with a public option and then let gradually other companies compete. And I think there's nothing wrong having private companies compete with the public option, but I think there will be more transparency. I think a lot of the, like you said, a lot of the private companies have a lot of behind the door corporate decisions made which are in their own interest. And I think public option will actually have all those decisions made based on what's best for the public. So I like the way you see the healthcare should be. And I also like that probably we should not necessarily mimic Canada just because they are north of us and we know them more, but there are other options in the world which are actually better than Canada. So I agree with you. I think so tonight we covered a lot. Tonight actually was one of the great live for all our listeners, our viewers. I think you obviously are not just a great community organizer, community supporter. You're a very compassionate physician. But I can also see, Dr. Bhatti, that you have a great vision, not just for the healthcare in America, but for also where our country should be going. So I really commend you. I see you going high places. I mean, I see just a great future in terms of what you're going to go beyond as a physician. So we'll be bringing you back, a few times a year to get an update on your clinic, update on your community work. And I really appreciate you coming on. And if you have any final thoughts, otherwise we'll end here.
Oh, that's so very kind of you. And again, it was my pleasure to be with you. And thank you for having me on your program. And I hope that people will take something from tonight and apply it to their daily lives and, try to do their best to make themselves and their families healthier.
Great. Thank you so much, Dr. Bharti. Thank you.